Chapter 1: The Physiatric History and Physical Examination. The Physiatric History and Physical Examination (H&P) serves several purposes. It is the data of the per- it is the data platform from which a treatment plan is developed. It serves as a written record that communicates to other rehabilitation and non-rehabilitation healthcare professionals. Finally, the H&P provides the basis for physician billing and serves as a medical legal document. Physician documentation has become the critical component in inpatient rehabilitation, reimbursement under prospective payment, e.g., interdisciplinary plan of care, admission screening, as well as proof for continued coverage by private insurers. The scope of the physiatric H&P varies enormously, depending on the setting, from the focused assessment of an isolated knee injury in an outpatient setting to the comprehensive evaluation of a patient with traumatic brain or spinal cord injury admitted for inpatient rehabilitation. An initial evaluation is almost always more detailed and more comprehensive than subsequent or follow-up evaluation. An exception would be when a patient is seen for a follow-up visit with substantial new signs or symptoms. Physicians in training tend to overassess, but with time the experienced physiatrist develops an intuition for how much detail is needed for each patient, given a particular presentation and setting. The physiatric H&P resembles the traditional format taught in a medical school, but with an additional emphasis on history, signs and symptoms that affects function or performance. The physiatric H&P also identified those systems not affected that might be used for compensation. Familiarity with the 1997 World Health Organization classification is invaluable in grasping the philosophic framework for reviewing the evaluation of persons with physical and cognitive disabilities. Excuse me. Identifying and treating the primary impairments to maximize performance becomes the primary thrust of physiatric evaluation and treatment. Because patients cared for in rehabilitation medicine can be extremely complicated, the H&P is constantly a work in progress. Confirmation of historical and functional items by other team members, healthcare professionals, and family members can take several days. Many of the functional items discussed in this chapter will actually be assessed and explored more fully by other interdisciplinary team members during the course of inpatient or outpatient treatment. It is imperative that the physiatrist stay abreast of additional information and findings as they become available, and that lines of verbal or written communication be directed through the medical leadership of the team. The exact structure of the physiatric assessment is determined in part by personal preference, training background, and institutional requirements, physician billing compliance expectations, proper linkage to the resident documentation, forms committees, and regulatory oversight. The use of templates can be invaluable in maximizing the thoroughness of data collection and minimizing documentation time. Pertinent radiologic and laboratory findings should be clearly documented. The essential elements of physiatric H&P are summarized in Table 1 to 2. Assessment of some or all of these elements is required for a complete understanding of the patient's state of health and the illness for which he or she is being seen. These elements also form the basis for a treatment plan. An emergence in the use of electronic medical record or EMR has significantly altered the landscape for documentation of the physiatric H&P in both the inpatient and outpatient setting. Tracking of variety of items to justify meaningful use of the EMR and the quality of the physician encounter is a commonplace. Among the advantages of the EMR are increased legibility, a certain degree of time efficiency afforded by the use of templates and smart phrases that can be tailored to individual practitioners or clinical presentations, automated warnings regarding a medication interactions or error, and faster and more accurate billing. Disadvantages includes the unacceptable use of copy and paste function, Kids don't do this at home, leading to redundancy among the consecutive notes and the perpetuation of potential inaccurate information. Automate, Automated importation of data not necessarily reviewed by the practitioner at the time of service, and alarm fatigue. As regulation of the hospital and physician practice and billing increases, the EMR will become more important in ensuring the proper and sometimes convoluted documentation required for safety initiatives and physician payment. The physiatric history. History-taking skills are part of the art of medicine and are required to fully assess a patient's presentation. One of the unique aspects of physiatry is the recognition of functional deficits caused by illness or injury. Identification of these deficits allow for the design of a treatment program to restore performance. In a person with stroke, for example, the most important questions for the physiatrist are not only the etiology or location of the lesion, but also what functional deficits are present as the result of the stroke. The answer could include deficits in swallowing, communication, mobility, cognition, activities of daily living or ADL, or a combination of these. The time spent in taking a history also allows the patient to become familiar with the physician, establishing rapport and trust. This initial rapport is critical for a constructive and productive doctor patient family relationship and can also help the physician learn about sensitive areas such as sexual history and substance abuse. It can also have an impact on outcome because a trusting patient tends to be a more compliant patient. Assessment of the tone of the patient or family, such as anger, frustration, resolve, and determination, an understanding of the illness, insight into disability, and coping skills are also gleaned during history taking. In most cases, the patient leads the physician to a diagnosis and conclusions. In other cases, such as when the patient is rambling or disorganized, frequent redirection and gentle refocus are required. Patients are generally the primary source of information. However, patients with cognitive, mood, denial or decreased insight, or communication deficits, as well as small children, might not be able to fully express themselves. In these cases, the history taker might rely on other sources such as family members, friends, other physicians, nurses, and medical professionals, or previous medical records. This can also have an impact on physician billing. The use of an interpreter to interview patients who are not fluent in the language of examining physician is mandatory. Caution must be exercised in using previous medical records because inaccuracies are sometimes repeated from the provider to provider, sometimes referred to as chart lore. Ooh, that sounds familiar. Chief complaint. The chief complaint is the symptom or concern that caused the patient to seek medical treatment. The most common chief complaints seen in outpatient physiatric practice are pain, weakness, or gait disturbances of various musculoskeletal or neurologic origin. On physiatric consultation on a patient in on an inpatient rehabilitation service, the predominant chief complaints are related to mobility, ADL, communication, or cognitive deficits, and the candidacy for inpatient rehabilitation. Unlike the relatively objective physical examination, the chief complaint is purely subjective, and when possible, the physician should use the patient's own words. A patient can have several related or unrelated complaints, in which case it is helpful to have the patient rank problems from most bothersome to least bothersome, while reinforcing that only one or two of those problems will be addressed at the current appointment. Specific circumstances of the patient offering a chief complaint can also allude to a degree of disability or handicap. For example, Knowing that an obese male carrier has a complaint of difficulty of walking because of knee pain could suggest not only the impairment but also an impact on his vocation and role as a provider for his family. Participation. History of present illness. The history of present illness details the chief complaint for which the patient is seeking medical attention, as well as any related or unrelated functional deficits. It should also explore other information relating to the chief complaint, such as recent and past medical or surgical procedures, complication of treatment, and potential restrictions or precautions. The HPI should include some or all of the eight components related to the chief complaint: location, time of onset, quality, context, severity, duration, modifying factors, and associated signs and symptoms. In this case example, the patient is a 70-year-old man referred by his neurologist for physical therapy. Because the patient cannot walk properly, that's the chief complaint. Over the past few months, that's the duration, he has noted slowly progressive weakness of his leg. Location. Subsequent workup by his neurologist suggests amyotrophic lateral sclerosis. That's the context or the diagnosis. The patient was active in his life and working up until a few months previously, ambulating without an assistive device. Another context. Now he uses a straight cane for the fear of falling, the modifying factor. Besides difficulty with walking, the patient also has some trouble swallowing foods. Associated signs and symptoms. Functional status. Detailing the patient's current and previous functional status is an essential aspect of the physiatric HPI. This generally entails better understanding of the issues surrounding mobility, ADL, instrumental activities of daily living or IADL, communication, cognition, work, and recreation, among others. The data should be as accurate and detailed as possible to guide the physical examination and develop a treatment plan with reasonable short and long term goals. Assessing the potential for functional gain or deterioration requires an understanding of the natural history, cause, and time of onset of functional problems. For example, most spontaneous motor recovery after stroke occurs within 3 months of the event. For patients with considerable motor impairments who recently underwent stroke, there are greater expectations for significant functional gain than in a patient with minor deficits related to stroke that occurred 2 years previously. Mobility. This is a long one, so please bear with me. Mobility is the ability to move about in one's environment and is taken for granted by most healthy people. Because it plays such a vital role in society, any impairment related to mobility can have major consequences for a patient's quality of life. A clear understanding of the patient's functional mobility is needed to determine independence and safety, including the use of or need for mobility assistive device. There is a range of mobility assistive devices that patients can use, such as crutches, canes, walkers, orthoses, and manual and electrical wheelchairs. Bed mobility includes turning from side to side, going from prone to supine positions, sitting up, and lying down. A lack of bed mobility places the patient at a greater risk of skin ulcers, deep vein thrombosis, and pneumonia. In severe cases, I'm sorry, I got lost with that. Just for a while, let's see. There we go. In severe cases, bed mobility can be so poor as to require a caregiver. In other cases, bed rails might be appropriate to facilitate movement. Transfer mobility includes getting in and out of a bed, standing from the sitting position, whether from a chair or toilet, and moving between a wheelchair and another seat, car seat or shower seat. Once again, the history taker should assess the level of independence, safety, and any changes in functional ability. Wheelchair mobility can be assessed by asking whether patients can propel the wheelchair independently, how far or how long can they go without resting, and whether they need assistance with managing the wheelchair parts. It is also important to assess the extent to which they can move about at home, in the community, and up and down the ramps. Whether the home is potentially wheelchair accessible is particularly important in cases of new onset of severe disability. Ambulation can be assessed by how far or how long patients can walk, whether they require assistive device, and if they can or sorry for that, and if they need rest breaks. It is also important to know whether any symptoms are associated with ambulation, such as chest pain, shortness of breath, dizziness. Patients should be asked about any history of falling or instability while walking and their ability to navigate uneven surfaces. Stair mobility, along with the number of stairs the patient must routinely climb and descend at the home or in the community, and the presence or absence of handrails should be determined. Driving is a crucial activity for many people, not only as a means of transportation but also an indicator and facilitator of independence. For example, older adults who stop driving has increased in depressive symptoms. It is important to identify factors that might prevent driving, such as decreased cognitive function and safety awareness, and decreased vision or reaction time. Other factors affecting driving can include lower limb weakness, contracture, tone, or incoordination. Some of these conditions might require the use of adaptive hand control for driving. Cognitive impairment sufficient to affect the ability to drive can be due to medication or organic disease, dementia, brain injury, stroke, or several mood disturbances. Ultimately, the risks of driving are weighed against the consequences of not being able to drive. If the patient is no longer able to drive, alternatives to driving should be explored, such as the use of public or assisted transportation. Law differ, law differ wildly from state to state on the return to driving after a neurologic impairment develops. Okay, folks, I think I'll be resting for now. My throat is a little bit painful. That's about 17 minutes of straight recording. Thanks.